Good evening, everyone. How are you all? All right, so today we are going to finish Gynecc for you, right? So we have already finished few of the topics from Gynecc. So we did in our last session, cervical cancer screening, family planning. We did discuss about this lower abdominal and pelvic pain in women. And then we have got rest of it left so far, right? So let me just open up John Motor because the rest of the things that we need to finish today all will be discussed from John Motor. Okay, so just give me 1 minute. I'll open up the gem. So have you guys started preparation? Like, have you started your gynae preparation already? Any questions from our last session? Okay. All right, guys. So let's start with chapter 94, which is abnormal uterine bleeding. So abnormal uterine bleeding, it's an important chapter for your exam. So there are lots of causes of abnormal bleeding from the uterus, but the most important one that we need to know is especially menorrhagia, which is excess menstrual bleeding. Okay? And there are lots of causes of heavy menstrual bleeding, but the commonest one is leiomyomata or fibroid uterus. Then it could be due to endometriosis, adenomyosis, could be endometrial polyp, could be pelvic inflammatory disease. So these are the main causes of heavy menstrual bleeding. And heavy menstrual bleeding is the commonest cause of iron deficiency anemia in Western world. So because most of these patients will bleed heavily during their period, and that can cause iron deficiency. That's why sometimes when they give you a case of they give you a case of heavy menstrual bleeding, and they ask you that what will be your initial choice of investigation. For heavy menstrual bleeding, our initial choice of investigation is iron study, just to make sure that patient is not deficient of iron. Okay. So these are all the causes of heavy bleeding. You can go through this, the history and examination. As we say that heavy bleeding, first of all, we do the full blood count and iron status. Full blood count to rule out anemia and iron status, especially serum ferritin, to make sure patient is not iron deficient. Transvaginal ultrasound. So it's not for every patient who is coming to you with a heavy bleeding, you will send them for an ultrasound. So there is some specific indication for it. So transvaginal ultrasound should be used when structural causes are suspected. Okay? And it is best to be done in the first 5 to 10 days of the menstrual cycle. So ideally, we would say that you would try with some medical management If you, like, let's say that if you don't suspect anything specific causing heavy bleeding, then you can just start with a medical management first. But if you suspect that there might be some secondary causes like fibroid, endometriosis, then yes, you can do investigation. So transvaginal ultrasound, why we do it is to check the endometrial thickness. An endometrial thickness more than 12 millimeter in premenopausal patient, more than equal to 5 millimeter in perimenopausal, and more than 4 millimeter in postmenopausal women requires endometrial biopsy. So endometrial biopsy is done to rule out endometrial carcinoma, and it can be a cause of heavy bleeding as well. So especially if you have got a patient with heavy menstrual bleeding, definitely after doing the blood test, you'll send them for an ultrasound. And if the ultrasound shows any of these characteristics, then you'll send them for endometrial biopsy. If the question asks you what is the definitive test or gold standard test for abnormal uterine bleeding, that is hysteroscopy and DNC. All right. So that's the step-by-step investigation of choice. Normally, we do the full blood count initially, that's for every patient, and then iron study. That should be your step. But most of the time in the exam, we see that they give iron studies as the option, not full blood count. But if full blood count is there, then yes, that comes first. So what is the management for heavy menstrual bleeding? So for heavy menstrual bleeding, first of all, there are medical, then hormonal, and then surgical treatment. So medical treatment are, you can give them tranexamic acid. Okay. So tranexamic acid is usually the first choice of heavy menstrual bleeding patient. So you can do that, or antiprostaglandin agents, like you can use mefenamic acid, like NSAIDs. So that's one of the initial choice of management that we can try. So NSAID, ibuprofen, naproxen, or mefenamic acid, that's one option. Then tranexamic acid, another option. Between tranexamic and NSAID, if they're asking you what is the initial management that you want to do, that will be tranexamic acid. Okay, so that's the initial one. But what is the most effective medical treatment? The most effective medical treatment is Mirena, which has a mean reduction of blood loss of 94%. So you can see that Mirena, or 52 milligram levonorgestrel IUCD, which causes 94% mean reduction of blood loss, which is lot. Okay, so if the question asks you what will be the initial choice of management, that's tranexamic acid. If they ask you what is the most appropriate medical treatment, that will be Mirena. Apart from Mirena, there are some other options, like you can give them oral progesterone, you can give them combined oral contraceptive pill, but these are not the best. So surgical treatment is only indicated if menorrhagia interferes with lifestyle despite maximum full medical treatment. So if medical treatment is not helping, then you can try some of the surgical option. Like if it is fibroid and patient's family is complete, then hysterectomy can be done. If it is fibroid but patient's family is not complete yet, then myomectomy will be the ideal one. Sometimes endometrial ablation, uterine artery embolization, all of these can be tried. Okay, so just keep it remembered that medical management, if it fails and it is causing significant lifestyle distress, then you can go for any of these surgical options. DNC is not a management for heavy menstrual bleeding. All right, so the option would not be DNC for you're not just sending the patient for DNC for any patient coming to you for a heavy menstrual bleeding. So it's not going to be the choice. And I don't think they give this kind of option in the choice, because NSAID, DNC, these are not usually our best option for heavy menstrual bleeding. So there will be some other good options that you can choose. Okay. So in patient who has acute severe uterine bleeding, your first option would be tranexamic acid. And then you can try any of the others, which is like progesterone, COCP. Those are the options that we have. So clear for everyone? So it's very simple. If they give you a heavy bleeding case, then if they ask initial management, that will be tranexamic acid or NSAID, whatever in the option. If they ask you most effective medical treatment, that's Mirena. And then last option is surgery. Moving on to fibroid uterus. So fibroid is a benign tumor of the smooth muscle of the myometrium. So myometrium is the middle layer of the uterus. And if that middle layer has got a tumor, that's what we call as fibroid. Most of the time, fibroid can be totally asymptomatic. But if it is symptomatic, then it causes menorrhagia, dysmenorrhea, pelvic discomforts, including dyspareunia. Sometimes patient can also have bladder dysfunction. Remember that fibroid uterus also can be a cause of subfertility or infertility. There is a complication that can happen with fibroid called red degeneration of fibroid. This only happens in pregnancy. Like a known fibroid patient, now pregnant, coming to you with pain, abdominal tenderness, and fever, you would think of red degeneration of fibroid. Okay? So not very common, and it's not very commonly seen as well, but you should know that if it's a non-fibroid in pregnancy coming with fever, abdominal pain, and tenderness, then definitely we should rule this out. So for fibroid uterus, when you examine them, sometimes you would be able to palpate the uterus in the tummy or in the abdomen. Investigation, transvaginal ultrasound. So ultrasound is very, very commonly they can find out fibroid uterus. Management will be same like heavy menstrual bleeding, because that will be the main presentation for this patient. So if patient having heavy bleeding, you will try the same thing. Then if it is really bad, Mirena will be the best option for this patient. GnRH analogs can be tried, but it's not very common that we give it to the patient, because you can only use it for 6 months. That's it. Surgical option, myomectomy. That means just removing the fibroid only. That's for patient who is childbearing and also they want to have more babies. Then you just do myomectomy. For patient who doesn't want baby anymore, family complete, for them like you can go for hysterectomy, endometrial ablation. Any of these can be done. Okay. So that was your heavy menstrual bleeding and most importantly, fibroid uterus. Any questions so far, guys? Intermenstrual bleeding and postcoital bleeding. This too is always something concerning. So if a patient bleeds in between the period or having postcoital bleeding, you have to make sure that there is no genital tract malignancy in this patient. All right. Postcoital bleeding is regarded as a cardinal symptom of cervical cancer. So very important that you rule that out. So lots of causes are there. You can go through it. So if a patient coming to you with a persistent postcoital bleeding, they will require to have a HPV co-test or cervical cancer co-test. So you remember the co-test? So where we do our HPV DNA typing and also reflexed LBC. So that's co-test. So any patient coming with persistent postcoital bleeding will have a co-test. Whether co-test positive or negative, they will need to have a colposcopy. Immediate referral is not required after a single episode. That's why we are saying persistent, more than one. If the suspected cause of postcoital bleeding is a cervical ectropion, still you need to send the patient to a gynecologist for colposcopy. Okay, so remember one thing, it's always the same case. Postcoital bleeding, more than one episode, patient will require co-test first, followed by colposcopy. Persistent intermenstrual bleeding will require gynecologist referral for a hysteroscopy with the endometrial biopsy. So if someone has got persistent intermenstrual bleeding, your initial investigation will be ultrasound. And then you do hysteroscopy with biopsy. Okay, hysteroscopy with endometrial biopsy is the confirmatory test. Postmenopausal bleeding. Postmenopausal bleeding suggests cervical or endometrial cancer. Always remember, postmenopausal bleeding, most likely it is endometrial carcinoma until you can prove otherwise. So it is like paid thing. Postcoital bleeding, cervical cancer. You have to rule that out. Postmenopausal bleeding, you have to rule out endometrial cancer. Okay. So if you have got a patient with postmenopausal bleeding, what will be your initial investigation? Ultrasound. And if the ultrasound shows that there is thickness more than 4 millimeter, then you need to send the patient to the gynecologist for hysteroscopy and DNC. Okay? And many times you can even do a endometrial biopsy as well. So we say in here, gynecologist referral is not needed if ultrasound shows endometrial thickness less than 4 and no suspicious feature. But if thickness is more than 4 millimeter, or even there is persistent bleeding, referral is indicated with a view to diagnostic procedure, which means hysteroscopy and DNC. Okay? So that's the step-by-step management for this intermenstrual, postcoital, and postmenopausal bleeding. Cervical cancer. So cervical cancer should be the diagnosis until proven otherwise for postcoital bleeding. Symptoms, we know postcoital bleeding, intermenstrual bleeding, vaginal discharge can be there sometimes in cervical cancer. And if you examine the cervix, you might be able to see ulceration. So if you see ulceration or a mass on the cervix, you would be very concerned. And definitely you do the cervical cancer needs a biopsy first. Biopsy means colposcopy, okay? So if you suspect cervical cancer, first definitely co-test and then colposcopy. And in the colposcopy, you normally take the biopsy. Endometrial cancer. It is the diagnosis until proven otherwise in any patient coming with postmenopausal bleeding. So what are the risk factors? This risk factor comes in exam, so try to remember it. Definitely it's patients who are more than 50, obesity, nulliparous, diabetes, PCOS patient who are taking unopposed estrogen. Like if you give a patient HRT, hormone replacement therapy, and you have only given estrogen without any progesterone, that sometimes can cause endometrial cancer. Same if someone is on tamoxifen, which is commonly used for breast cancer patient, that can also cause this endometrial cancer. Family history of breast cancer, ovarian, endometrial, or colon cancer can be a risk factor as well. Okay. So try to remember or memorize this risk factor because we have seen questions coming from here. And we know that endometrial cancer patient will come to you with postmenopausal bleeding. So investigations are the same. So you do an ultrasound followed by endometrial biopsy. And then even if you need more, then you do a hysteroscopy and DNC. Okay. So that's the step-by-step management. Any questions so far? Next, There is one condition called premature ovarian failure or premature ovarian insufficiency. Now, if a patient gets menopause before the age of 40, so menopause before the age of 40, whether it is medical or surgical. So medical means that like any condition which is causing the ovarian failure. Surgical means that if you have done a bilateral oophorectomy, like bilateral ovary removal for any reason, that can cause surgical menopause. Whatever it is, if menopause happens before the age of 40, that is what we call as premature ovarian insufficiency. So for such patient, you have to put that patient with hormone replacement therapy. So it is considered a hormonal deficiency. Requires hormone therapy with either combined oral contraception or menopausal hormone therapy. So ideally we say if someone has got premature ovarian failure, the best option would be to put the patient with hormone replacement therapy until the age of 50 at least. Okay? Yes, Dr. Khushbu, menopause before 40. Step-by-step management of endometrial cancer. So if you suspect a patient to have endometrial cancer, first you do a transvaginal ultrasound. If ultrasound shows endometrial thickness more than 4 millimeter, you do endometrial biopsy. And still, if you need to do more, then you go for hysteroscopy and DNC. If question asks what is the investigation of choice for endometrial cancer, that will be hysteroscopy and DNC. Sometimes during hysteroscopy, they can also do a endometrial biopsy. So like hysteroscopy will be the definitive test. There is no need of any other guideline for gynae. JAME is all that you need, Dr. Shironia. Premature ovarian insufficiency means if a patient has got menopause before the age of 40. Okay? And if it happens, then ideally you need to put the patient with a hormone replacement therapy up to the age of 50 at least. Because up to 50 is the usual time when a patient will get menopause. So you just cover that extra few years with hormone replacement therapy. Okay, like let's say someone has got, and by the age of 38, she is now totally menopausal. So from 38 until 50, these years, you're going to put the patient with HRT. And Dr. Flora, investigation of choice is in hysteroscopy and DNC. Last gynae class was duration of 1 hour 30 minutes. Okay, I'll have a look. Maybe because we had to stop in the in between. Okay, no problem, Dr. Shuha. Thanks for reminding. Moving on, guys. So that's this chapter that comes in exam under abnormal uterine bleedings. Chapter 97, menopause. So as we have been discussing, so I thought like let's just go on with the menopause at the moment. So menopause means when there is loss of ovarian function in female. In most of the Western country, it occurs between the age of 45 to 55 with an average of 51.5 years. So by the time a patient is 52, most of them will be menopausal. Premature menopause or premature ovarian insufficiency is menopause occurring before the age of 40. So how usually menopause happens? It's not like that women, they're having menstruation and the next month there is no menstruation. It doesn't happen like that. It's a gradual process where initially patient starts to find out that their period getting irregular and less bleeding every month. And so gradually it becomes irregular, and then at one time it stops. So during this period, when the patient gets irregular period and they get like scanty bleeding gradually, that time period is what we call as perimenopause. Okay? And then post-menopause is 12 months after the first bleeding or 12 months after the last period. So if a patient did not have any menstruation for the last 12 months, that patient will be termed as menopausal or postmenopausal. Before that, they will be termed as perimenopausal. Okay, making sense? So perimenopausal is that time period when the cycle gradually starts to change and at some point it stops. When it stops, from that time until 12 months, once 12 months is over, or you can say once 12 months of amenorrhea is there, then you call it postmenopausal or even menopausal. Okay, so they have made a summary of this. So there is premenopause, perimenopause, menopausal, which is the last menstrual period, and then postmenopausal is 12 months after the last menstrual cycle. Now, when a patient stops having the period, it means that they have lack of estrogen in their body. And previously, this estrogen was keeping their bone strong, keeping the bone density. When there is lack of bone density because of estrogen, patient can start to get osteoporosis. Osteoporosis is a condition in which the bone becomes porous and fragile, and it can easily break. And chances of having a fracture after a small fall increases if a patient has osteoporosis. We will discuss osteoporosis in a different class, but remember osteoporosis is common in patients who are menopausal because of lack of estrogen. So what are the clinical features of menopause? Once estrogen declines, patient starts to get menopausal symptoms, and that the most common one is hot flushes. So this classic vasomotor symptom is hot flush, which lasts for 1 to 2 minutes, begins in the chest and then is spread over the face and body. Patient can also get quite red and sweaty, and it might feel like patient having a panic attack, but it's not. And patient might feel that they have got a fever. So that's called hot flush, which is the commonest vasomotor symptom of menopause. Apart from that, night sweat, palpitation, dizziness, migraine, these are also quite common. Psychological symptoms can be there like anxiety, tearful, lack of concentration, mood changes. So all of this can happen. Urogenital, patient starts to get dryness in their vagina because of lack of estrogen, which was supposed to cause lubrication. And that is what we call as atrophic vaginitis. So when the vagina starts to become dry, thin, because of dryness, patient can also get painful sexual intercourse, which is dyspareunia. Okay, so atrophic vaginitis, vaginal dryness, dyspareunia, these are common. Bladder dysfunction can happen, like patient can complain frequency. They can also have incontinence or prolapse. So these are all the common symptoms of menopause. Okay. So you'll take a good history from the patient about all these symptoms, do a proper physical exam, and then investigation. This is where you can get quite confusing in the exam. Remember, menopause is a retrospective diagnosis which can be made after 12 months of amenorrhea in women over 50, after 2 years in women younger than 50. Okay, so diagnosis is made by taking a history. You don't need to do an investigation to confirm menopause. So if a patient has 12 months of amenorrhea after the age of 50, that's more than enough to diagnose menopause. And if someone is less than 50, then for them 2 years of amenorrhea. Investigating hormone level is unnecessary and often unhelpful with frequent fluctuation during perimenopause. But you can test the hormonal function or hormonal test for younger patients who are less than 45 getting menopausal symptom, amenorrheic women with a mirena, or women who have undergone hysterectomy. For these women, it is common practice to check for a elevated FSH. So if there is estrogen is low and FSH is very high, that will give you the confirmatory diagnosis of menopause. Okay, so low estrogen and increased FSH, that's the diagnosis of menopause. So remember, if it's a 50 and up patient, you don't need to do a hormonal test to confirm menopause. All you need to do is to see that if there is 12 months of amenorrhea. That's it. So don't get it wrong in the exam. Okay? Lots of differential diagnosis of menopause is there. Management. So management is important. So first of all, lifestyle modification, healthy diet, maintaining a healthy weight, relaxation. So all of these are important. But few patients might require menopausal hormone replacement therapy. So principal indication of menopausal hormone therapy is for the relief of troublesome vasomotor symptom. So remember, it's not for every symptom of menopause that you need to give HRT. You only give HRT for patient who has a very severe vasomotor symptom, like very severe hot flush, night sweat, palpitation. For them, only for those patients HRT is required, not for any other patient. The reason why it's not commonly used for everyone who is menopausal, because it comes with a risk. So there is increased risk of breast cancer, coronary heart disease, stroke, pulmonary embolism with prolonged use greater than 5 years. So it's not very common that we continue HRT for more than 5 years because of this risk. But again, it's not like that you can't use HRT after 5 years. You can use it after 5 years as long as patient is aware of this complication, as long as it is helping the patient. HRT can reduce the risk of bowel cancer and fracture, because definitely if you give estrogen from outside, it will again maintain the bony strength. So chance of fracture or osteoporosis will be low. So benefits and risks. So MST is the most appropriate treatment for menopausal symptom. It improves bone density, it reduces the fracture. See this one, the International Menopausal Society advised that MHT carries few risks when prescribed for symptomatic women without contraindication, if initiated less than 60 or within 10 years of menopause. If MHT is required beyond 60, oral estrogen and tibolone are not recommended because of increased stroke risk. Now try to understand this line because it comes in exam. It's for patient who is symptomatic of menopause, doesn't have contraindication. For them, it is quite safe, especially if you use it in a patient who is less than 60. After the age of 60, it is not a very well recommended treatment of choice. But if patient requires hormone replacement therapy after 60, you can't give them the oral form. You have to go for something like a patch or gel, not the oral estrogen. So what are the contraindications? So contraindication if patient has got history of breast cancer, endometrial cancer, undiagnosed vaginal bleeding, history of cardiovascular disease, active liver disease, migraine with aura, venous thromboembolic disease. So these are the contraindications that we normally would not go for hormone replacement therapy for this patient. MST and HRT is same. That's right. So it's the same thing. We just say it in a different way. Now, there are lots of regimens of hormone replacement therapy, and this is where a lot of people also get lost, like what to use. Okay. Now, first of all, you need to first think that is this patient perimenopausal or if this patient postmenopausal, because based on that, your choice of hormone replacement therapy will differ. Okay. Second thing that you need to consider is that if this patient has got uterus or not. So let's first find out that which one to choose if a patient is perimenopausal or postmenopausal. So you can see that these are all the regimens of hormone replacement therapy: estrogen, progesterone, SARM, tibolone, testosterone. A progesterone must be used with estrogen if woman still has a uterus. Why we say that? If you remember how menstruation happens that we discussed last class, that estrogen causes endometrial hyperplasia or endometrial growth. And after ovulation, when progesterone is produced, it causes gradual endometrial shedding. So if you give only estrogen to someone who has got uterus, gradually what will you do? You will just give estrogen and it will cause more and more endometrial growth and there will be no shedding. And that can eventually lead to endometrial hyperplasia, and endometrial hyperplasia can turn into endometrial cancer. That's why if a patient has got uterus, you have to give them both estrogen and progesterone. Okay? But someone who has got hysterectomy, only estrogen is all that you need to do. So there are lots of preparations. Estrogen comes as oral, transdermal patch or gel, and then topical vaginal preparation is also there. Nowadays, oral is not very commonly used. Patch and gel is very commonly used, but still, it's not like we don't use oral. We also use oral, but these are all very common. Now, you don't need to memorize this thing. Just remember that oral estrogen comes like estrogen comes as oral preparation. It comes as transdermal patch, transdermal gel, and then there is a vaginal preparation as well. How about progesterone? Progesterone is given to women with a uterus and can be given continuously or cyclically. Now, that is also very important. If a progesterone is not used in addition to estrogen, many women will develop endometrial hyperplasia, which has 5 to 10 times risk of endometrial cancer. Okay, so let me discuss this in my own way so that you understand. So, if a patient is perimenopausal, in a perimenopausal patient, you will give them estrogen continuously, but progesterone is called sequential or is cyclical. It's not continuous progesterone. So for women whose LMP was less than 12 months ago, progesterone should be cyclical. So you give them continuous estrogen and progesterone only given in the last 14 days of a cycle. Okay? Because that last 14 days of a cycle is where a normal patient would produce progesterone, right? So you're giving that progesterone in the last 14 days of a menstrual cycle, and eventually patient will get a bleeding after that. Okay? So for patient who is perimenopausal, in the initial 12 months, you will be only giving a continuous estrogen and a cyclical or a sequential progesterone in the last 14 days of a cycle. After 12 months of cyclical hormone replacement therapy, you can transition to a continuous estrogen and progesterone, which means once patient becomes postmenopausal, which means 12 months of amenorrhea, then you can give them continuous estrogen plus progesterone. Okay? Why we do that? Use of continuous estrogen and progesterone too soon after the last menstrual period can result in unpredicted breakthrough bleeding. So if we start estrogen progesterone as a continuous, then sometimes it can cause like too much of a breakthrough bleeding, and it will be like bothersome for the patient because you will not be able to know when you are getting the bleeding. So unpredictable breakthrough bleeding is not something those patients usually want. So if you give them just cyclical, they will know that after 14 days of taking the progesterone, they are going to get a withdrawal bleeding. Okay? So that's for perimenopausal women. So when we prescribe the menopausal hormone therapy, you will be chosen based on all of this. So if uterus is intact, then you need to give them both estrogen and progesterone. If uterus is not there, just estrogen, either oral, transdermal, or gel. Okay, so whatever you want to give, but give it. If a patient has got previous hysterectomy, they don't need progesterone. Should be prescribed continuous estrogen in either a transdermal or oral preparation. Transdermal patch is better for patients who can have history of deep vein thrombosis. Okay, but normally we try our best to avoid giving estrogen to patients who might have recurrent history of venous thromboembolism. But even after that, if really we need to go for it, then we would go for a transdermal patch, not oral, because oral increases the risk of a stroke, risk of clot. So there are some side effects of this hormone replacement therapy. So for hormone replacement therapy, it can cause nausea or breast symptom. If patient having nausea, then you just reduce the estrogen dose. If patient is having heavy bleeding, then you can give them you can increase the progesterone. That can be done as well. Duration of treatment. Remember, there is no mandatory limit to the duration of hormone replacement therapy. Many people say that no, after 5 years, you can't give hormone replacement therapy at all. But you can, because Menopausal Society recommend there should not be any limit. Women who are prescribed MHT should be reviewed at least annually to check if they really need it. If they don't need it, then they can stop it. Provided there is no contraindication, women can continue the hormone replacement therapy as long as it addresses therapeutic goal, symptom, and quality of life. So remember that just because it is more than 5 years doesn't mean that you have to stop MHT. So you guys now understand that for menopause, if a patient has got vasomotor symptom which is severe, you can give them hormone replacement therapy. What if patient's only complaint is atrophic vaginitis, like vaginal dryness? So if patient's main symptom is vaginal, like local problem, dryness, atrophy, in that case, your first line treatment can be a non-hormonal lubricant. If lubricant doesn't help, then you can go for a low dose estrogen, like a vaginal estrogen. So you can ask the patient to use estrogen cream or pessaries. Very commonly used in Australia. So if a patient has got something like atrophic vaginitis, you can start them with estrogen cream or pessaries. Now let's say someone is there who has very troubling vasomotor symptom, but has a history of a stroke, history of maybe breast cancer, where you can't give them hormone replacement therapy. So when hormone replacement therapy is contraindicated, but patient having troublesome symptom, then non-hormonal treatment is another option. So the non-hormonal treatment, the first line is SSRI and SNRI. So as part of SSRI, paroxetine is better. As part of SNRI, venlafaxine is better. You can use either paroxetine or venlafaxine. We talked about premature ovarian failure. Idiopathic is most common, but other than that, Turner syndrome, lots of other causes are there. Investigation, as I said, you check the FSH and estrogen. FSH will be high and estrogen will be low. And cornerstone of treatment is menopausal hormone therapy until the median age of menopause. So that's what I told, that if a patient has got premature ovarian failure, you have to give them estrogen or hormone replacement therapy until 50 to 51. Okay. So that's all about this chapter. Any question? We haven't seen any relationship between HRT and Alzheimer. And HRT increases the risk of clot formation. And if there is clot formation is one of the risk factors, clot can cause anything. Heart, it can cause DVT, PE, it can cause heart attack, it can cause a stroke. Estrogen patch is better for like if you want to reduce the risk of stroke or clot, for them estrogen patch is better, or transdermal patch. COC as an alternative to hormone replacement therapy? No, you can't. So that's a different thing. So menopausal hormone replacement therapy does not act as a contraception. In the same way, COC does not act as a menopausal hormone replacement therapy. Moving on to the next chapter, chapter 98, vaginal discharge. Very important for exam. So there are lots of causes of vaginal discharge. One, it could be just a physiological discharge. Other than that could be candidiasis, bacterial vaginosis. Sometimes discharge can be a presentation of malignancy. It can be due to STI like chlamydia, Neisseria, mycoplasma, sexual abuse. Okay, so lots of causes are there for patient with vaginal discharge. The most common cause of vaginal discharge are physiological discharge. Normal physiological discharge is milky white or clear mucus. So many patients can have a physiological milky white vaginal discharge, and it is quite common, and there is nothing wrong with that. Okay, so the predominant bacterial flora is lactobacilli, which produce lactic acid from glucose, and this lactic acid keeps the vaginal pH acidic. So if by any chance there is a change of this pH, then there is a chance that patient can get this kind of physiological discharge. With physiological discharge, there will be no smell or no pruritus, which is very important. Ideally, it should be white or mucus, but when it is left on the underwear, by the end of the day, it can turn yellow in contact with air. So just because it is a yellow discharge doesn't always mean that it is something like infection. So clear mucoid discharge, by the end of the day, it can turn a bit of yellowish. But the main thing is there is no odor, there is no pruritus. For this kind of discharge, nothing needed to be given. All you need to do is reassurance and explanation that this is physiological. Coming to some of the infective causes. So, vulvovaginal candidiasis is one of the common cause of vaginal discharge, which is caused by a fungus or yeast, which is Candida albicans, and then there is another one, Candida glabrata. Then there is bacterial vaginosis, and in bacterial vaginosis, the normal vaginal flora will be replaced with some abnormal anaerobic bacteria, such as Gardnerella vaginalis. And usually this is the cause of bacterial vaginosis. Then there is Trichomonas vaginalis, which is not common in Australia, but it's common in patients, especially remote Aboriginal and Torres Strait Islanders. Okay. Now this table is very important. Try to memorize this. So Candida albicans, which is vaginal thrush or candidiasis, the discharge is whitish in color. It's very thick and it looks like a cheesy white appearance. There is no odor, but it can be quite itchy. Trichomonas vaginalis is yellow-green in color. It is mucopurulent, bubbly, and profuse. But it is malodorous with a fishy odor. In case of bacterial vaginosis, the color is important because it's whitish or grayish. It is also bubbly, profuse, and watery, and malodorous. So these two are quite easily you can get confused because both of them are quite same. But the color is important. When you see yellow-green, you think of Trichomonas. When you see whitish, grayish, malodorous, fishy odor, you think of bacterial vaginosis. Okay, so color matters a lot. Just because we know that most common cause of vaginal discharge are infective causes, don't think it cannot be due to a cancer. It can be a presentation of cancer also. So definitely we should rule out any cancer of the vagina, cervix, uterus. We should rule out any possibility of a STI. Cervical screening co-test should be performed in patient with unexplained persistent blood-stained vaginal discharge. So if you have got a patient with blood-stained vaginal discharge, that patient should have a co-test. So there are a few investigations in here, high vaginal swab, then whip test. So you can go through this in your own time. You can see that sometimes during our investigation, we also do this wet film examination. In the wet film examination, if you get a clue cell, that's most likely bacterial vaginosis because you don't get clue cell in any others except bacterial vaginosis. Okay, so that's important to remember. One of the very important thing to remember that vaginal discharge can also happen in children. Most newborn girl will have some mucoid white vaginal discharge. And it is common, it will disappear by 3 months of age. But from 3 months of age up to puberty, vaginal discharge is usually minimal. So if a child, like if a parents bring a child, like a newborn with some mucoid discharge, don't be alarmed. It's likely that it is normal. okay, and disappear in 3 months' time. But from 3 months up to puberty, if a child presents with vaginal discharge, you will be concerned. If discharge is profuse or offensive, then take a introital swab, which can find Streptococcus, Haemophilus, Gardnerella, anything can be there. So you don't do a vaginal swab in a children, you do an intraoital swab. That's the difference. For adult, you do vaginal swab. But for children, if you really need to do it, it will be an introital swab. The most common cause of vaginal discharge in elderly is atrophic vaginitis. We discussed about it that it happens after menopause. Patient can also present to you not just with vaginal dryness, but also yellow non-offensive discharge. So atrophic vaginitis patient can also have this yellowish discharge. And patient can have a bit of spotting or bleeding with coitus. And when you look into the vulva vagina, it will look dry, thin, atrophied. Then you can give them estrogen cream or pessaries. Moving on to candidiasis. Very important, very commonly asked in the exam. So candidiasis, as you can remember, that patient will present to you with a thick, white, cheesy discharge. With that, patient will have intense vulval pruritus. So that's very important that these patients with the discharge, they get quite itchy. And if you do a vulvovaginal exam, you might be able to see brick red erythema of the vulva or vaginal wall. Like this. You can see it's quite red. Now, there is always something, the risk factor is there, which leads to candidiasis. Patient doesn't just get candidiasis out of nowhere. So patient can be immunocompromised, and that can be the cause. Could be uncontrolled diabetes, pregnancy, immunodeficiency. Even combined oral contraceptive can cause it. Same long-term antibiotic, long-term steroid. So any of these things can be the cause of recurrent candidiasis. Okay. So how do we investigate and manage candidiasis? So once you know that it could be a case of candidiasis, you will first take a swab. So you take a vaginal swab to confirm the diagnosis and find out which species of candida is causing this. Okay. Once you have taken the swab, you don't need to wait for the swab result to come back. Empirically, you can start treatment for first-time presentation. So if someone coming for the first time with candidiasis, you can start with them any of the vaginal azole cream. So you can give them clotrimazole, miconazole, iconazole, any of the vaginal azole cream can be given for 1 to 7 days. Okay. Nystatin is best reserved for recurrent cases or if there is local reaction to the azole. So if a patient, you tried vaginal cream, patient says, no doc, I can't use it, it's quite messy or I'm getting adverse reaction, then for them you have an option of either changing it to nystatin. So nystatin is a vaginal pessary, or you can also give them a single dose of oral antifungal, which is oral fluconazole. Okay. So a recommended initial regimen is vaginal azole cream. If patient does not want cream or has reaction to the cream, your option would be either nystatin, vaginal pessary, or best option would be oral fluconazole, just a single dose. Okay. Now there is a question like chronic vulvovaginal candidiasis or recurrent candidiasis. We say that if a patient has got more than 4 episodes of candida in a year, that's chronic or recurrent candidiasis. For chronic or recurrent candidiasis, first of all, definitely you'll need to take a swab, and better is low vaginal swab for this case. So you take a low vaginal swab, and once swab is done, once it is confirmed that yes, this is a recurrent candidiasis, your treatment will be fluconazole for 3 days apart, followed by maintenance with fluconazole for 6 months. So you don't need to know the dose, but remember that for recurrent candidiasis, your treatment of choice is oral fluconazole for 6 months. Okay? So giving you a summary, if you get a patient who has got thick, cheesy, white vaginal discharge with intense pruritus, first of all, you take a swab. If it is the first time, then you start the patient with vaginal azole cream. If patient is not able to tolerate that or it's not getting any better, you go for best option would be oral fluconazole single dose. What if patient getting more than 4 in a year? Every time patient comes to you with a discharge, you need to take a swab to find out the species and to confirm the diagnosis. And once it becomes recurrent candidiasis case, then oral fluconazole for 6 months will be the treatment. Okay. What if, when you took the swab result came back for Candida glabrata? For Candida glabrata, the treatment is boric acid intravaginally for 14 days. So remember, it's different. You can see in here the time to achieve remission varies from 2 weeks to 6 months. So sometimes what we do is that we can review the treatment after 3 months rather than continuing it up to 6 months. Okay, so that's something that we can also try. So 3 months time we review the patient to see that if this patient will require another 3 months. Trichomonas vaginalis. Trichomonas vaginalis is, as I said, that it is a sexually transmitted illness. In Australia, it is common in older women and women from regional and remote areas, which means Aboriginal and Torres Strait. Okay, so how do they present? Yellow-green discharge, profuse, mucopurulent, and also very malodorous. So when you get something like that, for that patient, the treatment, first of all, you take the swab, and once swab test comes back positive for trichomonas, you will give them oral metronidazole as a single dose, or you can even try 400 twice a day for 5 days. Just remember, metronidazole is the treatment, or tinidazole. Sexual partner has to be treated as well simultaneously. So because it is a sexually transmitted illness, even if the sexual partner doesn't have symptom, he should be treated simultaneously. Bacterial vaginosis. So bacterial vaginosis is mainly, as I say, that it can, the normal vaginal flora will be replaced by some abnormal bacteria. And in this patient, a whitish gray discharge, no vulvitis or vaginitis. So this is not itchy like candidiasis, but it is quite malodorous, very fishy odor comes from patient who has got BV. Clue cell can be found on wet preparation, and you can see that it can look something like that. So again, you take the swab. Once swabs come positive for BV, then you can treat them with metronidazole, either orally or even you can try vaginal gel. For pregnant, you can't use metronidazole, so for them you can use clindamycin. Okay, so clindamycin for resistant infection or during pregnancy. Treating male partner is not recommended because it is thought that it is not a sexually transmitted illness. So bacterial vaginosis is not a STI, but trichomonas is. So because BV is not sexually transmitted, You don't need to treat the partner. Now, I want you guys to follow one other thing. So it's called STI Australia. So in STI Australia, so for any kind of STI related question, you will go into that STI guideline Australia. That's a very important guideline that we ask you to follow. So in here, you will be getting all the important ones like chlamydia, anogenital wart, gonorrhea. So lots of things are there. So try to read the important ones. Okay, like if we see here, they have got bacterial vaginosis, candidiasis. Okay, so if you go to the candidiasis part, you can see here. So you can go through the diagnosis. If you come to the management, so same thing they have written. For initial, you can use azole cream. Alternative is fluconazole. For recurrent, what you have to do. For Candida glabrata, what you have to do. So it's written over. All is here. More like let's say someone is pregnant and having candidiasis. What would you do? For those patients, you can't use fluconazole or boric acid because this is contraindicated in pregnant patient. For those patients, you will be able to use the azole creams. So the cream will be the only option that you can try, and you might need to go for a little bit of longer course for those patients. Okay, so you can go through the STI guideline if there is any other confusion that you have. So that's all about vaginal discharge. So Dr. Chandima, so when a patient comes several times, every time you do swab, that's right. Okay. All right, guys, let's take a 10-minute break. And then after that, we will finish the rest of the planning. Okay. Thank you. All right, everyone, let's start again. Okay, yes, Dr. Chandini, you are right. So that is what you are supposed to do. And Dr. Disank, osteoporosis, I think we discussed it as part of end of the course notes. There is no specific video that I can refer, but it should be discussed in our end of the course classes. Okay, let's start with breast pain and breast lump. So these are the two other gynae chapter as well. So breast pain can be due to cyclical mastalgia, can be non-cyclical mastalgia. So cyclical mastalgia is the common cause of diffuse breast pain, which means that cyclical means the pain has relationship with the menstruation. So it mainly starts in the latter half of the menstrual cycle. So we say that just before the menstruation, patient starts to get breast pain. And then once menstruation starts, the pain gets better. So it has definitely a hormonal basis of it, which means that with the hormonal fluctuations, patient can get breast pain, which is what we call as cyclical mastalgia. The main cause of cyclical mastalgia is what we call as benign mammary dysplasia, or also known as fibrocystic breast disease. We'll discuss all of this later on. Non-cyclical mastalgia is what's like patient having breast pain, but it doesn't have any relationship between the menstrual cycle. It is also common, but there is no specific cause. It can be associated with a condition called mammary duct ectasia. And also, we should rule out all other causes like any cancer, infection, or even myocardial ischemia. Okay, infection. So one of the infection of breast soft tissue or connective tissue is what we call as mastitis. So mastitis is common in patient who is like breastfeeding. So breastfeeding mother or nursing mother, they can easily get mastitis. It should be regarded as a serious urgent problem because left untreated, it can form a breast abscess. Most commonly, it is caused by bacterial infection like Staphylococcus or Streptococcus, but you can also get mastitis from candidiasis. But how we know it is candida? Candida infection usually causes a severe breast pain, producing a feeling like hot cords. So if they say that, if they give this line or they say that severe breast pain feels like a hot cord, then you can think of candida infection causing mastitis. So you can go through these checkpoints and everything. We talked about cyclical mastalgia, which is common in between 30 to 40-year-old, usually bilateral, related to menstrual cycle. Non-cyclical, we also talked about it. Management. So for both type of mastalgia, you need to make sure you reassure the patient, and you have to, like, you might need to do a breast examination. So all the regular, like a normal ones, sometimes if it is really bad, you can advise them to take some analgesia like paracetamol or ibuprofen. Okay, so there is no specific treatment needed for this nostalgia. It's all about reassurance and then understanding that this can happen. Okay, and if it is really painful, take some painkiller. That's it. There is another cause of breast pain, which is what we call as Tidje syndrome or costochondritis. So costochondritis is, you know, that the rib cage, which is like the costal cartilage, the junction between the rib cage and the cartilage, which is the costochondral junction. So this part, costochondral junction, sometimes can be strained, especially in patient with a persistent cough. The pain can appear to be in the breast, and sometimes it can be quite tender. Okay, so pain is acute. You can even feel a palpable swelling in the costochondral cartilage. X-ray will be normal. It is self-limiting, but sometimes it can take months for the pain to subside. So you can also sometimes try to infiltrate with local anesthetic and steroid. So that's one of the things that can be tried. But initially, you would just give patient paracetamol and NSAID for the pain. If it is really bad, then sometimes steroid with local anesthetic injection into the costochondral junction can be tried. Okay, so that's costochondritis. Next, mastitis. So we were talking about mastitis, which is basically, it's a cellulitis of the connective tissue of the breast. Most of the time, because it is restricted to lactating women, it is associated with cracked nipple or poor milk drainage. So it happens in first-time mother because sometimes they have difficulty with breastfeeding. And even if they know how to breastfeed, they might not be draining the milk properly. So some milk might stay and that can get infected. The other one that if there is lack of proper positioning of the baby, and sometimes baby can also like cause a cracked nipple. Now, if it is cracked, then infection from the skin, which is a staphylococcus, can easily get into the nipple and then go into the breast. So that's how the mastitis happens. Remember, breastfeeding from the affected side can still continue. As long as it's not a breast abscess, the mother can still continue breastfeeding from that mastitis breast. And that's usually the treatment also. So how the patient will present? Initially, patient will come to you with a breast pain. Sometimes there might be even a red swollen area. So if that is the case, you would think that, well, then there is an infection is happening. So you'll need to advise the mother to continue breastfeeding from the affected site. Okay? Encourage milk expression from the infected breast manually or by breast pump. That means draining the infected breast is the main treatment. Now, if patient starts to get fever, then you can also start the patient with antibiotics such as flucloxacillin or dicloxacillin. If allergic to penicillin, then cefalexin can be tried. If it is due to candida, then fluconazole is the treatment. Now, how we know that it is breast abscess or it is mastitis? We say that if redness and tenderness persist more than 48 hours and an area of induration develops, then a breast abscess has been formed. Basically, the most important thing that you should notice on the stem is that if questions say that, yes, there is a tender, swollen lump, and the lump is fluctuation positive. So if fluctuation test is positive on that lump, that's a breast abscess. If fluctuation test is negative, that's still mastitis. Okay? If you want to confirm that it is breast abscess or not, then you can do an ultrasound. An ultrasound can confirm it. So once it is confirmed, the treatment is serial aspiration with a large bore needle under ultrasound guidance. It's not incision and drainage. So all other abscess, we go for incision and drainage, not breast abscess, because it can cause like a fistula. So that's why it's better not to do the incision and drainage in a breast abscess. So you go for serial aspiration with a wide bore needle by ultrasound. And sometimes patient might need 3 or 4 aspiration, and also give the patient antibiotic as an adjunct treatment. Now, until the breast abscess has been completely drained, you would advise the mother not to breastfeed from that side. Once it is completely drained, then they can resume breastfeeding from that side. Okay? Clear everyone how to differentiate between mastitis and abscess, what's the treatment and everything? Moving on to breast lump. Very, very important for exam. So what is the commonest breast lump? So the commonest lump is mammary dysplasia, 32% cases. So that comes in exam. So what is the commonest breast lump? Commonest is mammary dysplasia. Fibrocystic disease is also a common cause of cyst, especially in the premenopausal phase. So as I said that breastfeeding can continue with provision of lactation support. It's like you can continue as long as you have drained it. So you can see that first they have aspirated it. Once aspiration is done, then you can go for it. You definitely, when there is a breast abscess, you are not going to like breastfeed from that side. That's not ideal because there might be pus as well, right? So it's not ideal that you would continue the breastfeeding from that side if there is an abscess or pus there. So as soon as you can drain the pus, then yes, breastfeeding can continue. And definitely, if you're not doing the breastfeeding, then still you need to do the emptying of the breast. So that means that the patient needs to empty the breast, even if it's needed with some breast pump or manual expression, that breast needs to be emptied. Breast lump. So commonest lump is mammary dysplasia. And then there are lots of causes of breast lump, which we will discuss. If you get a patient who has come to you with a breast lump, the test that we do is called triple test. So triple test starts with history and breast examination, followed by an imaging. Either you do an ultrasound or mammogram, and then FNAC or core biopsy. So you have to do all these three tests before you can say that the lump is normal. So triple test is indicated for almost every patient who comes with breast lump. Okay, moving on to some of the important cause of nipple discharge or breast discharge. So if the discharge is blood stained, the commonest cause of blood stained nipple discharge is intraduct papilloma. But if it is, let's say that it's a more than 60-year-old having a blood stained nipple discharge, you would try to rule out intraduct carcinoma, and that will be your most likely cause. So the age is very important when you actually get breast lump in a patient. Okay. Greenish gray, commonly you can find out in mammary duct ectasia or fibrocystic breast disease. Same yellow can be found in fibrocystic intraduct carcinoma. Milky white, definitely if a patient is lactating, then and also hyperprolactinemia patient can get milky white discharge. Okay, so blood-stained intraduct papilloma, greenish-gray mammary duct ectasia, these two comes in exam. So there is a condition called Paget disease of nipple. It doesn't come in exam that much, but you can give it a read. What are the red flag points for breast lump? Breast lump in a elderly patient is always red flag, especially above 60. Apart from that, if the lump is hard and irregular, if there is associated skin dimpling, puckering, bloody nipple discharge, nipple eczema, and if you get that classic body orange skin feature, these are all red flags. So we were talking about doing the triple test for breast lump. First, history and examination. The next part is imaging. So who we are going to do ultrasound and who we are going to do mammogram. That's one thing that comes in exam. So according to GEM, if it is less than 35-year-old, bilateral ultrasound is better than mammogram. You would only do mammogram if ultrasound is suspicious. So less than 35, you would do an ultrasound. More than 50, you would go for bilateral mammogram. So what if it's between 35 to 50? You do both, mammogram plus ultrasound. Okay. So less than 35 ultrasound, more than 50 mammogram. If it's between 35 to 50, both mammo and ultrasound. So that's usually the breast imaging summary. Then we have got FNAC. So this is a very useful diagnostic test in solid lump. So if you have got a solid lump, then yes, after ultrasound or mammogram, you will need to send the patient for FNAC. There are some tumor marker also for patient who has got breast cancer. We check for some of the tumor markers, especially we look for estrogen receptor, we look for progesterone receptor, which we will discuss later on. Okay. This is the summary of investigation of a breast lump. So let's say a patient coming to you with a breast lump younger than 35. So you have done the history and examination, then less than 35, you do an ultrasound. If older than 35, you do both mammo and ultrasound. And we know that if it is more than 50, we do mammo. Then you do an ultrasound or mammo, you found that lump is cystic. That means there is fluid inside the lump. Then you aspirate. That means you aspirate the fluid and then send it to the lab. If it is solid, then if you do it, you do a FNAC. If FNAC shows that it is a suspicious lump, then you do a excisional biopsy. Okay, so that's the step-by-step management of breast lump, which comes in exam a lot. Now, if we come here, that we have got a cystic lump, then we aspirate. After aspiration, we did not find anything, which means that it was not a cystic lump because you aspirate, but nothing came. So that means it is solid. For solid, you would go for FNAC followed by biopsy. What if it is a blood-stained aspirate? If it is blood-stained, you will send the fluid to the lab for a cytology. If cytology comes positive for cancer cell, definitely needs a biopsy. If cytology comes back negative, then you just review the patient every now and then. Okay. If aspiration comes as greenish yellow aspirate, you can send the fluid for cytology and follow the same step, or you aspirate, greenish yellow fluid came out, but there is still a bit of lump left, like a residual lump, even after you aspirated few fluid, but a lump is still there. That's a solid lump. That will also need a biopsy. If there is no residual lump, just review, no need of biopsy. Okay, so that's what we normally do in this case. It's not punch biopsy, Dr. Khan, it's called fine needle biopsy, FNAC, aspiration biopsy. So again, it's not needed for exam, punch biopsy, shape biopsy. All you need to know, it's called FNAC. So you use a fine needle to take a small area of that lump. How we normally do the FNAC. So this is what we would do if it is a cystic lump, not a solid lump. Solid lump straight goes for FNAC. Okay, so try to remember this chart. So what is the indication of excision biopsy or excision of a lump? Indication one, if you have aspirated a blood-stained discharge from a cystic lump. So if the cyst fluid is blood-stained, lump does not disappear completely with aspiration. That means there is a residual lump, and the swelling or the lump recurred within a month after aspiration. Okay. Moving on to some specific causes, breast cancer. Breast cancer is uncommon under the age of 30, but once patient reach the age of 60, it increases a lot that patient can have a breast cancer. Always remember that if the question gives you that if 50-year-old coming to you with a solid painless lump on the breast, what's the most likely cause? Most likely cause will be breast cancer. Same patient, if it is 30-year-old having a breast lump, you would not think breast cancer as the most common cause. So the common thing always should come first. Okay. 90% of breast cancer are invasive ductal carcinoma. And other than that, it could be lobular, papillary, and other things. Risk factor, you should read the risk factor of breast cancer, important for exam. Clinical feature. Majority of the patient comes with a lump which is painless, and the lump is hard and irregular. Patient can also have, remember, 10% of breast lump, which is cancer, can be painful. So just because it's a painful breast lump in a 60-year-old, don't think it is not a breast cancer. Even a painful lump can be a breast cancer. Now, just like colon cancer screening, breast cancer screening comes in exam. And it is a bit harder than colon cancer screening. Okay? So you'll need to learn the breast cancer screening from RSCGPA Red Book exactly the same way like we have done for colon cancer. Okay, I will come into that later on. So once you have done all the triple tests, and with the biopsy you have found that this is a breast cancer. What's the treatment? So first of all, you need to know that if it is a breast cancer carcinoma in situ, or is it an invasive cancer? If it is a carcinoma in situ, then sometimes you will have an option of just removing the lump, which is lumpectomy, and then you do a radiotherapy on that area. And that's commonly done for, let's say, ductal carcinoma in situ. But if it is an invasive ductal carcinoma, for that patient, mastectomy with a breast reconstruction surgery is the ideal choice. Okay? So that's what is written in here. Ductal carcinoma in situ is not uncommon, and it means that it is non-invasive. It's still limited and located just in a single duct. And if you leave it, then it will get a invasive ductal carcinoma later on. So for this patient, you will be giving both option of total mastectomy or breast conserving therapy, which is that lumpectomy, and patient can choose it from here. Apart from lumpectomy and mastectomy, sometimes you might need to go for chemotherapy in patients who has got a bit of metastasis. Sometimes there are hormonal therapy available for some patient who has got estrogen or progesterone receptor positive. Like we have anti-estrogen agent tamoxifen for patient who has estrogen receptor positive. Okay. So those are usually the common treatment. It doesn't come that much as part of the treatment. Mainly breast cancer screening comes in exam. Okay. Next, fibrocystic breast disease. It has a lot of name. As you can see, fibroadenosis, mammary dysplasia, lots of name. Fibrocystic breast disease is common in between 30 to 50. It is hormone related, which means that patient usually get symptom, which is mastalgia, just before menstruation. So patient will come to you with like painful breast lump, especially during the menstrual period. Okay, so hormone-related pain and tenderness, premenstrual discomfort and increasing pain or swelling, and during menstruation, it can get increased in size, and after menstruation, the pain, swelling, the size can get low. So it usually settles after the period. This kind of patient in the stem, they will say on breast examination, breast is diffusely nodular or lumpy. So these are called lumpy breast or nodular breast. So if they use this term, then think that they're talking about fibrocystic breast disease. So for this patient, again, you do the triple therapy, you do like ultrasound, mammo, and if there is a discrete lump, you might even need to do a FNAC. So you do everything. And once it says no, there is nothing cancerous, then you can manage it accordingly. And the management is just like symptomatic. If patient gets nostalgia, then give some analgesic, okay? But nothing else you can do about it. Breast cyst also common between 40 to 50. And it usually gets better after patient gets into menopause. So when would you think of breast cyst? If the question says that there is a firm, relatively mobile mass. So if it is a cystic lump on the breast, which is firm, a little bit mobile, not hard like breast cancer, then you would think of breast cyst. Fibroadenoma. Now, this is important. So, fibroadenoma is common in young patients, especially less than 35. So, usually in 20s, if a patient coming to you with a smooth, mobile lump, so it is one of the like it is that much mobile that it is called breast mouse. That means it is not hard, so it's a smooth, firm, and quite mobile. Then you would think of fibroadenoma. So even if it is like less likely to be cancer, you would be doing ultrasound and FNAC. Once you do all of those and it comes back positive as fibroadenoma, you can reassure the patient. So patient can be reassured and followed up until fibroadenoma is stable. So you can do another ultrasound in 6 to 12 months time to see that if it is getting any worse. Okay. So fibroadenoma is benign tumor and there is nothing needed to be concerned for this patient. But if you get a fibroadenoma like breast lump in a patient above 40, then excision biopsy is also indicated. That is the only time excision is indicated if it is a fibroadenoma like breast lump in a patient above 40. Or if it is if it is a very large fibroadenoma, like more than 3 to 4 centimeter, then you can go for a biopsy. Okay. So breast cyst is common in between, like you can see the age. Age is important. It's common in between 40 to 50, perimenopausal. And breast cyst, usually you can see that you will be a relatively mobile, firm mass. Whereas fibroadenoma is rare after the age of 30 or 35. So you will get it in between like 20 to 30-year-old, let's say. And it's quite mobile, smooth and firm. So when they say that 20-year-old or 25-year-old coming to you with a firm, smooth, mobile breast lump, then you think of fibroadenoma. Whereas 40-year-old coming to you with a firm and let's say relatively mobile, or they can say that firm mobile lump. Even if they say that firm mobile lump, you think of breast cyst because it is 40. Okay, so age will matter a lot. But if they want you to choose fibroadenoma, they will emphasize on the point that it is quite mobile. There is a very important topic, which is fat necrosis of the breast. So fat necrosis usually happens after a large bruise or a trauma that the patient might had even years ago. So following a chest trauma or a large bruise, a patient can develop a lump on their breast. Okay? So it can closely resemble a cancer. If untreated, it usually disappears, but diagnosis can only be made on excision biopsy. So if you have got a patient who you think that it could be a fat necrosis because patient might have a chest trauma and now having a lump, even if you think it is fat necrosis, still you have to do the full triple test. If they ask what is the confirmatory test for this patient, that will be excision biopsy. Ductal papillomas. So ductal papilloma is the most common cause of blood-stained nipple discharge. But you have to make sure that this can be also ductal carcinoma. Okay, so age is matter a lot. So in those patients, you do the triple treatment or triple test. So you'll be doing all the initial things, but only way to confirm that it is not a breast or it is not a ductal carcinoma is that you have to do a excision biopsy of the duct. But same thing, you do the triple test in this case. Mammary duct ectasia. It is also a benign condition. In this condition, sometimes one of the duct or multiple duct can become dilated and form a lump. The lump is usually near the areola. It is firm or hard, very tender, and poorly defined swelling. But the important thing to look at is this toothpaste-like nipple discharge. So patient can have a greenish yellow discharge or a toothpaste-like nipple discharge. So when you see all of this, firm, tender, poorly defined lump, and having a toothpaste-like nipple discharge, you would think of mammary duct ectasia. These things can get complicated with recurrent abscess and fistula. So for this patient, again, you need to do the triple test. Okay, and only after doing the triple test, you can confirm the diagnosis. Okay, now I'm going to show you the breast cancer screening RACGP guideline. And Dr. Rabia, we can't upload the lectures immediately after the class ends. It's not possible because, first of all, we need to download this huge video, then upload it in a different software, then add it into the portal. So it takes time, and because it's late night, we finish the classes, we can't do it. It has to be done in the next few days. Okay. Okay, now this is going to be tricky. Given the time now, you must be tired. So breast cancer screening is usually a bit difficult because there is a lot to understand from here. So for breast cancer, first of all, you need to know who is low risk, moderate risk, and high risk. So for low risk patient or average risk patient are patient who doesn't have any history of breast cancer in the family. So every female should have a mammogram from the age of 50 up to 74 years of age every 2 yearly. So that's just same like colon cancer. Everyone, whether they have a family history or not, they will need to get a mammogram every 2 yearly from 50 to 74. So they are low risk, but someone who has got a one first degree relative diagnosed with breast cancer after the age of 50, that's also low risk. Same thing, one second degree diagnosed at any age, two second degree on the same side of the family diagnosed after the age of 50, that's also low risk. So these three is usually the one that you can remember, but the main thing is this one. One first degree after the age of 50 is a low risk. Okay? Going to the moderate risk. Moderate risk patient is one first degree relative diagnosed before the age of 50. For this group of patient, annual mammogram from 40 years of age may be recommended. So this group of patient who has a first degree relative diagnosed with breast cancer before the age of 50, you can do mammogram every year from the age of 40. Okay? Then there is two first degree relative on the same side of the family diagnosed with breast cancer. So at any age, so if there is two first degree diagnosed with breast cancer at any age, for that patient you can go for 2 yearly mammogram from 50 to 74. Okay, which means still you will follow the same thing, 2 yearly mammo from 50 to 74 for them. Only time annual mammo is needed if a first degree diagnosed before the age of 50. Two second degree diagnosed with breast cancer, but one of them was before 50 and on the same side of the family. That's also moderate risk. Okay, the question actually comes from this one. So this one is one of the question that usually will appear, and then another one is someone who has a first degree after the age of 50. That's the two which is quite important. High risk. So potentially high risk is patients who are also high risk for ovarian cancer, two first degree or second degree relative on one side of the family diagnosed with breast or ovarian cancer, plus one or more of the following. So two first degree or second degree on the same side of the family, plus another relative with breast cancer or ovarian cancer. So now becomes three. So three people, either first degree, second degree, has got a breast cancer. Breast cancer diagnosed before the age of 40. So if any of them from these two first degree or second degree, any of them diagnosed before age 40, any of them diagnosed as bilateral breast cancer, breast and ovarian cancer in the same women, breast cancer in a male relative. So any of this, that will make it a very high risk patient. Okay, so it will be same like this. Let's say that your patient who is 50-year-old, her mother got breast cancer at the age of 56, her sister got it at the age of 60, and then her aunt, maternal aunt, got breast cancer at the age of, let's say, whatever age it is, even at 60. So you have got 2 first degree plus additional relative with breast cancer. That's also high risk. Okay. So for a high risk group of patients, you need to refer them to a cancer specialist or a family cancer clinic for individual risk assessment with a possible genetic test. For this patient, sometimes you can even give chemo prevention with tamoxifen or raloxifene or aromatase inhibitors. So this can reduce the risk of cancer in a high-risk patient. Alternative can be a prophylactic mastectomy with salpingo-oophorectomy. So that's why for high-risk group of patients, you need to send them to cancer clinic for further assessment and genetic testing, and they will give the chemoprophylaxis. For high-risk patient, also they will need annual breast imaging with mammo, MRI, or ultrasound. Now, there is no specific age that they have given here. So once you send the patient to cancer clinic specialist, they will define at which age this patient needs to start the annual breast imaging. Okay. So that's all about the breast cancer screening. So definitely go through this a little bit more from the Red Book. It will make sense. But the main one that comes in exam is the one that I have talked about. So first degree before the age of 50, annual mammo should be done from the age of 40. Okay. And Dr. Shabab, we discussed about the colon cancer screening. Sometimes like other mentors can get a bit confused because it is a confusing topic. So whatever I discussed in the class, please keep it as the main one. Okay, just to make sure that it doesn't get confused. So controversial statement, if it happens in the class, just ask me so that I can confirm it, and please go with that. So as far as the new guideline, it is still not in the Red Book that we start screening from 45. So as long as it's not on the Red Book, we don't follow it. Okay, so it is still from 50. So RSCGP Red Book is not on the Facebook page. It's on the Google. You just need to write RSCGP Red Book 9th edition. It will come up. As I said, Dr. Sana, you will be following the RSCGP Red Book guideline. Okay? It's the one that is given as a new that you are saying. That is just a publication. It's still not followed in Australia. Nowhere we follow it. So it's not a guideline yet. Maybe once they do a new edition of screening, then it can. But still now we would follow the Red Book. And Dr. Nayasha, for the question that you have shared, young girl with heavy menstruation, also having pain. So when there is pain with heavy menstruation, better to choose mefenamic acid because mefenamic acid helps with dysmenorrhea and menorrhagia both. If it is only menorrhagia, then tranexamic acid is better. So there is no specific driving topic, Dr. I. So For driving related questions, we go through some of the topics at the end of the course classes. So at the last few classes, we would go through this, but not at the moment. For driving related topic, if you want to explore, then there is a fitness to drive like guideline. There is like I think about 200 pages. So you can always just write fitness to drive Australia guideline and you'll get that PDF. So basically you can go through that PDF. Mainly in the exam, epilepsy comes in exam and few other things. But as long as you know a little bit more about epilepsy, that will do. All right, everyone. So that's all for tonight. Hopefully you got a good idea about Gynecc. Now, the only thing that we don't discuss from Gynecc is chapter 96 and chapter 99, which I want you guys to go through in your own time. Chapter 96 is premenstrual symptom. Very easy. You just need to go through that, like what is PMS and what is PMDD, which we even discussed in our class, in our one of the questions solved. But chapter 96, maybe 5 or 6 pages, just read it once. And then there is chapter 99, which is valvular disorder. Nothing much from there. The only thing that you need to read is lichen sclerosis. Let me quickly go through that so that you know what to read. So from this chapter, there is valvular disorders, chapter 99. So for this, only 2 topic is important. One is this lichen sclerosis, in which you get this well-defined white figure of 8 plaque. Okay. So it's a itchy valvular rash. And the main thing is that it is chronic, complicated. It can develop squamous cell cancer in 2 to 6% case. So that's why it is a bit important. So if a patient coming to you with a white wrinkled plaques around the valvular area with genital pruritus, you would think of lichen sclerosis. Okay. So in this patient, first you need to confirm the diagnosis by doing a biopsy. Once it is confirmed, then a potent steroid ointment is the treatment of choice. This patient will require lifelong surveillance with 6 monthly checkup with the gynecologist. And only time you would do surgery if it is a complicated case of lichen sclerosis. You can go through a little bit from this vulvovaginitis in prepubertal girls, like how mild vulvovaginitis presents. So give it a read. Another important topic that comes in exam is called Bartholin cyst. So Bartholin cyst is sometimes Bartholin gland can get obstructed. So you know that like just at the posterior end of the labia majora, you have got the Bartholin gland, and Bartholin gland, it has a duct. So if somehow the duct gets obstructed, then there will be more and more fluid accumulated, and it will cause a cystic structure, which is Bartholin cyst. So it's a painless vulval swelling at the posterior end of the labia majora. Now, if it is just a cyst, it will be painless. Just a lump will be felt. But when it is painful, red, it is infected. So when it is infected, and Bartholin abscess can form, which can cause a painful red tender vulval lump. So if it is a Bartholin abscess, ideally you go for an incision and drainage, and then send the pus for microscopy and culture, and also start the patient with antibiotic. If it is a recurrent Bartholin abscess, that patient might need a surgical marsupialization. So in that case, you don't you do a incision and you keep it open, and you allow all the discharge, all the abscess to drain, and you leave it open for a few weeks, and then you close it. So that's called surgical marsupialization, only done if it is a recurrent Bartholin abscess. The most common cause of this abscess is E. coli, but if it is a sexually active woman, you need to also rule out STI. Okay, so that's Bartholin cyst and abscess. All right, guys, so that's actually all that you need to know from Gynecc. Hopefully, you can finish all of it. Next class, we'll be doing obstetrics, and following obstetrics, we'll be doing a Gynecc obstetrics question solve. Okay? Thanks, everyone. Have a good night. Take care.